Francis Price is going to be our first speaker, and Dr. Price is the head of the Price Vision Group and Cornea Research Foundation in Indianapolis. He's authored over 200 peer-reviewed ophthalmic publications and book chapters, and has been the principal investigator in 100 clinical studies of ophthalmic devices, medications, and techniques. Dr. Price will speak to us about how the Lenstar has optimized his workflow.
Thank you. It's a pleasure to be here, and it was great to get the exercise coming down the hall C. So, as Warren said, I'm going to talk about how it's helped our practice out and optimized our cataract workflow. I can get this, there we go. Only relevant financial disclosure is Haag-Streit. So, Warren will probably talk about the RBF formula, which is great for normal eyes, but when we've looked at our practice, only 43% of our IOL implants are for normal eyes. We take care of a lot of unusual problems. 12% of our cataracts are previous refractive surgery, 25% are combined with primarily DMEC, 3% keratoconus, 6% have had a previous PK or DAUC, and 11% are a variety of other problems. Now, we have a high concentration of ocular surface disease. And so with all of our testing, the place we start out is to make sure the ocular surface is in good condition. And you can call this dry eyes, you can call it ocular surface disease, but whatever the issue is with the ocular surface, if that's not in good shape, you're not going to get good information. We've all heard garbage in, garbage out. And so you can get wide fluctuations in your measured Ks, the amount of astigmatism, the axis of the astigmatism, if you don't have a good ocular surface. So that's where we start first, because we want to make sure our measurements are accurate. So we actually start out with topography in our practice first. And I've shown here, this is not one of the worst ones by any means, but it shows a picture on the left of an eye that came in and was a little bit dry. And there's the SAI on this one, the looks at the regularity of the surface of the cornea. And what's nice is that in the picture on the left, it comes out red. And I've been able to train my techs that if it's a red picture, we can't use these pictures unless there's something wrong, like an irregular graph that accounts for it. So we treated this patient for a month with dry eye treatments. And the picture on the right is how it looked after treating their dry eyes. And you can see that the amount of cylinder decreased substantially, as did the axis, so it would change the way that we would plan the surgery if we're trying to come out with a refraction of plano after surgery. So we have to get the ocular surface in good condition before we do any other testing. So we have two tracks. We have the easy track if people don't have ocular surface disease, our testing is good. We do the Lenstar and everything's usually pretty easily. We have the more difficult tracks. And when we have the more difficult tracks with complicated eyes, it's nice to have a system that allows input into what's a good measurement, where you just don't take the picture and you have no idea of how good it is. And it's often helpful to be able to change the reference points as well, and essential to eliminate poor measurements. And it's nice to be able, when you're looking at IOL formulas, to compare different formulas for a lot of these abnormal eyes. So in particular, how did the Lenstar help us? Well, the first thing we were able to do is download its readings into a PDF that could go into our EMR, and that got rid of a little data entry error and helped those doing the calculations not have to be next to the machine to do all of that. We were able to get more rapid measurements in uncomplicated patients, and we're able to get lens thickness for the first time, which helps the accuracy of our calculations. Now, I look at this as like when we moved from film to take our slit lamp and fundus photos to when we went to digital. And so the big advantage of digital is that you know right away if you got a bad photograph, and if it's bad, you delete it and redo it, just like we do on our phones. It used to be that if we had a bad photo, we wouldn't know till we got the film back a week later, and by then it might be too late or the condition had changed. So this is the same thing with our IOL calculations. You don't want to be at the point when you're doing your calculations to realize that some of the measurements don't make sense, and then you have to remeasure the patient. So our techs can now tell if the measurements are good, and they get this right while they're doing the testing. If it's not right, they retake the measurements or delete the bad ones. And so the techs can also reset the endpoints if needed on some of the tests like white to white and axial measurements. And so this empowers our techs, and that of course leads to happier techs and an easier flow in the office. So what we have here, and I don't know, I guess I don't have a mouse to show any of this. These are the axial length measurements, and on the left we have the measurements, and I want to start out by saying usually the Lenstar is right on, so we don't have very many of these where it's off, but the measurements of where the beginning and the end of the lens was off just a little bit, so the tech could go back and reset that to make it a little bit more accurate, as you see on the right. Here are the K measurements, and what we usually have is a series of 5 different readings that each comprise four times that it's done the measurement, and it averages all of that. And so on the left side, you can see that there's a blink in one of these, so you may want to delete that one. That's the reason that we got rid of the red bar at the top, the first group of measurements. And on the lower one, there was a blink as well, so we remove those and we get more accurate measurements. Probably the people in the front can see that the standard deviations improved, and there was some small differences in the amount of the Ks. But the main thing here is to see that you can actually look at the measurements and tell if they were accurate. You can make sure they're good. If they're not good, you either repeat them and certainly delete all the ones. You want to make sure you have a total of at least 3 of these that you can average at the end. This is another one here. This is a patient, it looks like that's probably had a graft before, and we have an abnormal reading in number 3, and that's where there was a blink. That's why there's no dots. So I'm going to show you these here. This is a post-PK patient, which we have a fair number of. And so you can go in and the machine will automatically give you the triangles that it sees that are wrong. And you can go in and also look for the outliers. If one of the readings is way off for where the K is, where the axis is compared to the others, then you can get rid of it. And you can also look at this, and if they're all they don't make sense, well then you, as I said before, you need to retreat the ocular surface. This is another post-PK patient where you can see that we have some readings on the left side that are quite a bit divergent. As I mentioned, it'd be really nice if we had a mouse up here to do a pointer. I don't think this is a pointer. No, we don't have a pointer either. What it is, if you look at the purple line that outlines the limbus on the left side, you can see that it's offset a little bit, and it's out over onto the sclera or the limbus a little bit more than it should. So what my technician did was they made the circle for the limbus smaller, and they moved it a little bit over the center to the left and downward. And if you look at the 2 pictures, the upper one is before they repositioned it, and then they repositioned it down below. And so with a lot of abnormal eyes that make the readings difficult, this has been helpful for us to just make things for our calculations a little bit more accurate. Now I want to put this in perspective. We actually have the ability now to more accurately predict the vast majority of our IOLs preoperatively. And I think this has been very important. In my particular case, when I was a resident, we didn't even use IOLs. When I started practice, I remember a surgeon telling me that he only used 18 diopter lenses, and that really worked for everybody. And then, of course, around that time, if you just got a 20/40 result, that was a great endpoint. But that's not the way it is now. Now we use multifocal extended depth of focus lenses, and these are great options for patients, but you need a very accurate postoperative refraction. You don't want your sphere or cylinder to be off more than half a diopter. Higher refractive errors lead to these lenses not working well, and they're much less forgiving than a monofocal lens. And just to put this in perspective a little bit more, this is a publication that just came out in December in JCRS. And this is looking at the refractive results of cataracts in Europe, where they used the femtosecond laser. Now, they divided up the groups according to what their preoperative vision was, But when it was all said and done, they had about a 72% rate of eyes that had a refractive error of less than half a diopter or less. And that's not really acceptable if you're going to do premium IOLs. You have to have better endpoints than that. And these surgeries were done up until 2015, so they didn't have some of the more advanced calculating formulas at that point. But we need to really get all this much more accurate. We need to use optical biometry and some of the new formulas. Thank you.